I mean, one of the difficulties in dealing with parents and with children, so for example, with the spinal deformity situation, is the uncertainty and the waiting. We have seen over 600-700 spinal outpatients in 2008 alone. 102 of them were new patients. In 2008 alone, and this is the data we presented at the Irish Orthopaedic Association meeting, we were able to operate on 40 patients. These are major deformity cases now. So we did 40 patients had major deformity surgery, and that required a total of 67 operations, and that was in 2008 alone. So you can see that we were only managing a surgery to waiting list ratio of 0.4, and our concern is, of course, that with children, we don't necessarily have time on our side.
Yes, because their spines are growing all the time, and if it's curvature of the spine, it'll get more curved the longer you leave it, and the more damage will be done, which is why there's a real urgency in getting these operations over and done with.
That's correct. In children's orthopaedics in general, whether you're talking about the spine or the hip or the knee or anywhere else, it's true to say that if your child has a deformity or a problem relating to their growth or development, growth is not your friend. And growth will tend to lead to further progression of the condition. And therefore, as children wait, their situation in a significant proportion may deteriorate. In our group, we had a couple of alarming findings for 2008. Number one, the curve magnitude, the magnitude of the deformity of the spine, which should be straight or less than 11 degrees in curvature, the magnitude at the time of surgery was close to 80 degrees, which in the Western world is a reflection of almost a system failure. Either delay in diagnosis, delay in time to being seen, and also delay in time to surgery. So there are measures, if you like, of systems not functioning as they should.
Okay, but just let's take the case recently, Pat, now that you've had a number of operations that had to be cancelled, not least that of Jamie Murphy, who now has got to go and have her operation abroad. Was it necessary to cancel those operations?
I can't really, how to say, refer to an individual or a specific case.
Yes.
Jamie, this patient who has been referred to is not my patient. It's one of our team's patients. But I have cases like this. And one of the difficulties is that on average I can operate on do one major spinal deformity case a year. Now, I'd have to recognise that Crumlin have been fantastic in providing for increasing numbers of surgeries over the years. We've increased, our data shows from 2006, from 96 cases in 2006 to 147 cases in 2008. So that's nearly a doubling in the numbers. Temple Street have managed to increase the numbers slightly, but they did about 20 last year in total.
But now you're having to cut back on these cases because of the budget cuts.
One of the facts of life with the budget cuts is the recent financial situation is that by imposing a financial cutbacks or strain or system cuts on us, we've had to reduce our operating sessions by 20%. So I'm losing at least one operating list in every 5. And this is across all surgical specialties, and thus, of course, I won't be able to. If we continue with this model, we can project that people on my waiting list may, if we didn't, increase the resources in terms of theatre time and operating time, etc., that we might have a waiting list of up to 2 years, which is, it's not clinically, morally acceptable, not to mind ethically or financially acceptable. I mean, it costs far more in the long term to deal with these problems.
Yes, of course it does.
And the other thing I'd like to say is that, necessarily saying, well, we can ship the problem to the UK. We have a lot of the expertise, the infrastructure, the people who have all the people resources that we need. In fact, we almost have the infrastructure in terms of building resources that we need. Sending them to another jurisdiction just means you're putting resources into another health service.
But was there no other option but to cancel these operations to save the money?
Maybe I didn't make that quite clear. These operations are often postponed, and the reason for that is that we have cases of dire need, and we have cases that are moderate need, and if I have 100 people on my waiting list, for argument's sake, or currently it's about 75, I think, then I have to repeatedly look at these patients and see which ones need the surgery most urgently, because there are different categories of need. And when you have a limited resource, then we have to provide in the category of need. And one of the groups of children which need surgery, say more urgently in that whole spectrum, are children between 1 and 5 years of age. If you're, now this thankfully is a very small proportion, but if you're that young and you have scoliosis, your heart, your lungs, your thorax is still developing, and of course your spine is linked to the rib cage. And we know that the result of progressive, untreated scoliosis at an early onset is very bad.
So in other words, an older child
may have to wait,
even though he or the parents of that boy or girl may have been told that that operation is going to happen very soon, which may have been the case with some of the situations we've seen more recently. But if that is the case, if already you're having to cancel operations now, and of course there's huge controversy about the budget cuts at Crumlin Hospital, and you're saying that the waiting lists will only get larger, which is kind of an obvious logic, you would say, what's going to happen then? Because we were talking this morning about the so-called on-board SNP recommending a series of budget cuts across many departments, not least the Department of Health is going to be cut as well. So it looks like you're going to experience even more cutbacks in the future.
Sure, I suppose that's one of our major concerns. In that group of 40 patients in 2008, a number of them, 25% of them, had multiple operations. Multiple operations means we had to do multiple operations because they had such severe deformity that it had to be done in a staged fashion. Now, that is not cheaper. That's far more expensive. So if you're talking about using resources effectively, that's absolutely not the way to do it. I'm no expert in health budgets or strategies or anything like that. I don't have a figure or a head for numbers and calculations, but intuitively this is not the way to do it. There are other ways to do it, and sure, I do accept that different departments may have different restrictions placed on them, but I'm saying in terms of clinical need and even simple health economics, the one thing you don't want to be doing is cutting services so much that it's going to cost you more to provide the care at a later stage with poorer outcome.
But do you see, because you've worked abroad in some hospitals, Pat Kiely, is there a way to provide a more efficient service which will maintain waiting lists at very manageable numbers, allow surgeons like yourself to operate on the children who need these operations, and do so effectively within current budgetary constraints?
I think that if you want the best bang for your buck, if you like, in terms of health related activity, you have to have care related activity, and you have to have some way where your funding is dedicated directly to care and linked directly to care.
Like performance related, you're
performance,
saying
I had a chat with one of the senior members of the government, and one of their difficulties in the health situation, and I purely empathise with them, and they have a very difficult situation. They have to restrict the amount of money going in certain directions. Public service is one of those areas. How do you increase efficiency? Well, the only way you can do it, obviously, is if you put in money and you get a certain product in return. There's no, as I can understand it in Ireland at the moment, no real clear correlation between the money that goes in and your productivity on the other end. So you can turn that around the other way, and you can say, well, why don't we make the funding completely dependent on productivity? And by that I mean everyone dependent on productivity. So my salary, for example, and our nurses' salaries and our anaesthesia salaries and everybody in the hospital, it depends on productivity. Then you have an activity-related funding system. And in the areas around the world that I've worked, in Australia, in the North America where I visited, the only models that seem to work in an efficient manner, and also the private health service, they all work in an activity-related funding manner. It's logical, and you can see there, you can plan, and you can see how, for example, with a scoliosis service, if we had to do 40 operations, which cost somewhere between 40 and 60,000 euros each, I'm told, that would have given us a budget of about 2 million euros. Now, I don't have a budget or our department doesn't have a budget of 2 million euros to plan with or to configure our services. But if we see that, and we see that we need to do 60 or 80 operations next year, we can say, right, well, what's that going to generate in funding? And yes, we will employ another consultant. Yes, we can finally get maybe more anaesthetic backup, which is sorely needed in Crumlin. Yes, we can get more specialist nurses in orthopaedics. Yes, we can function almost as an independent economic entity and actually be far more cost effective.